another story, something to get off my chest.
Hello and welcome to another Piper Pod. Today we're going to continue with pharmacology and we're going to look at medications involved in the treatment of hypertension. Now, hypertension is a pretty big topic for everyone. I mean, in the year 2000 it was estimated that over 1 billion people suffered from high blood pressure, and that was just the people that actually got tested. So it's prevalent in our line of work. Many people are on antihypertensives, and you'll know many others that could benefit from a little bit of knowledge of what hypertension is and the risk factors associated with it. So we'll get stuck straight in, and we'll just start with a bit of a review of what our blood pressure is. So I'm not going to insult your intelligence too much, but when we talk about blood pressure, it is obviously a mixture of cardiac output versus peripheral resistance. Now, if we focus on cardiac output just for a little bit, there's 3 factors that really determine cardiac output. Now, obviously, that is the stroke volume and the actual rate in which it's going at. Now, the third factor is what makes up that stroke volume. So you have a mixture of preload versus the associated pressure of afterload. Now, the reason I draw importance to that is because obviously heart rate is very simple to understand. The more beats per minute you have, the greater your cardiac output is going to be. The higher your stroke volume is, the greater your cardiac output is going to be. But what feeds the stroke volume is a mixture of venous return versus the amount of pressure they find in the afterload. Now, one of the main things that influences preload, apart from peripheral resistance that we talk about, is the actual concentration of osmotic values in the blood itself. So if you have salt, for example, sodium is the greatest electrolyte that has the best osmotic draw. So if you have a high sodium concentration, then you're going to have more water held into the vessel, which is going to increase preload. But in comparison, something that doesn't get talked about very often is actual proteins. So if you have a huge amount of protein in your bloodstream, whether that's albumin, globules, ferritin, amino acids, doesn't really matter which one, they all have a massive osmotic draw. So they have a huge metabolic weight, which means they have a huge metabolic draw, and that is what gives us a large amount of blood volume. And that really determines what our cardiac output is going to be. Okay, so that's the main points for cardiac output. When we look at vascular resistance, we have a difference within preload, sort of, but mostly peripheral resistance will determine the afterload of the heart. Now, the factors that affect peripheral resistance is you have your simple blood viscosity. So the more viscous your blood is, the more amount of solids in your blood, the more peripheral resistance is going to be felt because it's no longer a nice fluid. But what controls the actual diameter of the arterioles, if you will, is your nervous system and your humoral system as well. Okay, so the hormonal system. We're going to look closer at the hormonal system because we have closer links to that with the actual medications that we give. But sympathetic nervous system is something that causes visceral resistance, so that's what actually gives us our vasoconstriction. And also your renal control plays a huge part in your peripheral resistance as well by increasing the amount of solutes to water ratio that you find within your blood. So the bottom line is when we're looking at something like blood pressure, it's designed in order to maintain perfusion throughout the body. Now, the greater the blood pressure is in number, the bigger the risk. Now, obviously we have things built in place that allow us to regulate our blood pressures. Those things are called baroreceptors. But what you'll find very early in your clinical career is that baroreceptors are very subjective to peer pressure. And I use pressure in the pun term because if your blood pressure is high, let's say it's sitting at 140 and it's constantly sitting at 140 systolic, then your baroreceptors will accept it. and they'll accept that 140, and they'll actually fight to keep it at 140. So when things will actually drop down and your blood pressure gets lower to 120, your body will actually kick into normal mechanisms that it would do if you had low blood pressure to get it back up to 140. So in other words, your body gets very comfortable at staying at 140 unless certain things change. Now, as far as what can change, we'll go through a few of those today outside of pharmacology, and then obviously the interaction of pharmacology can intervene as well. Okay, so looking just a little bit closer at the humoral control, just as a reminder to let you know what's at play. The humoral involvement, which is a much long-term, slow, stabilizing control, as opposed to the nervous system that just kicks in the sympathetic state, blood pressure increases, lasts a little bit, and then the blood pressure drops back down again. Okay, that's associated with exercise, with running, with killing something, all those sort of fight or flight response. But our humoral control is what small changes within enzymes and hormones that actually help regulate the blood pressure just that little bit further. So in the event that a blood pressure change is detected, we'll go for the low because that's what actually activates all of these things. Then all of a sudden your kidney and your liver release two chemicals. Okay, so angiotensin and renin will actually be released at pretty much the same time. And when renin activates angiotensin, it becomes angiotensin 1. Okay, when angiotensin 1 is activated by the angiotensin converting enzyme, which is found in the lungs, so it actually takes place in the lungs, it becomes angiotensin 2. Now, angiotensin 2 is where things actually start happening. We get vasoconstriction of the arterioles, and at the same time, we get a release of aldosterone. Now, aldosterone increases the amount of sodium uptake, and thereby water uptake, and also excretes calcium and hydrogen ions into the urine itself. Okay, so then we have an increase in blood volume and vasoconstricted, all caused by angiotensin 2 activating certain receptor sites, and then the blood pressure rises. Now remember when I said that your blood pressure wants to maintain at what the baroreceptors are used to, meaning this same system is in play even when you are hypertensive and then get relatively hypotensive. Okay, relatively meaning still possibly clinically hypertensive. This system can come into play. Other things to consider when we're dealing with people with hypertension. Now obviously we're not the ones that are prescribing this medication, and medication is never the first point of call when you're dealing with hypertension. But things that we need to look at is we need to have an assessment of the actual person, the person as a whole stance. So we need to take a baseline set of vitals. We need to have a look at the heart forces of the blood pressure associated with pulse pressures and the rhythm. Okay, irregular heartbeats are usually associated with hypertension. If you get a double beat, doubling your cardiac output, it has associations with hypertension, or at least it can. If there's any diastolic volume over 190 millimeters, then that is pretty significant, because what that means is we actually have an increased circulating volume. So we actually have a huge amount of circulating volume, or we have a stable state of vascular resistance. Okay, now this could be due to strips, or it could be due to atherosclerosis, but most of the time it's got to do with having just a large osmotic draw based blood system. Okay, so that means that your resting blood pressure is always high. When we take your blood pressure, don't just take one. Take them in different situations so we can assess if there's any problems with people regulating their blood pressure. Okay, if people can get a normal blood pressure lying down and then as they sit up they get a massive drop, then that is signs of postural hypertension, and it's also signs of inability to adapt. If these people go on medications, it can be very, very dangerous. Okay, that's true. If you're thinking it's a blood pressure problem, take the blood pressure on both arms. It's a good way to have a an early intervention for aortic dissociation, nice big one, but you can also pick up subtle changes like your aneurysms in the descending aorta as well. You obviously have a different blood pressure on both arms. Now, hypertension itself is asymptomatic. So no one's going to come to you unless they've taken their blood pressure and say, I have high blood pressure. So think about the signs and symptoms associated with the bad sort of hypertension. So people that get the headaches, the peripheral edema, they get nosebleeds, blurry vision, dizziness, they're the main ones. If you're getting blood pressures around the 180 over 120, okay, that's high-end hypertension, and it's usually associated with organ damage. So that's a hypertensive crisis. If that blood pressure is also associated with blurred vision, anxiety, seizures, or peripheral headaches, then you are moving into a more of an acute hypertensive crisis and more of an emergency state, just to let you know. If they've had a recent blood test, check their serum levels, or recommend that their serum levels get tested. If you're thinking about getting put on diuretics, serum levels are something that must be monitored all the time. Now think about your other causes of blood pressure increases. So anxiety, stress, anger are definitely emotions that are associated with high blood pressure, as to with certain diets. So stimulants, sympathetic stimulants like caffeine recently can raise your blood pressure because it has a vasoconstrictive response as well as an increase in your cardiac output from your heart rate. So have a look at what they've been on. Exercise post during the recovery phase, they're going to have heightened blood pressure as well. And then other things like chronic smoking, lack of exercise can play a big part in someone's blood pressure. Bottom line is when people are going on medications, you need to educate them on the risks associated with what happens when the blood pressure falls. Okay, how they can feel. They may get edema. They may have electrolyte displacement. So educate them on all of these changes that can occur before they go on blood pressure medication. When they're on blood pressure medication, illustrate the importance of monitoring them. Okay, monitoring their vital signs, their electrolytes. Always listen to their lungs. If you're on a particular types of antihypertensives, it plays a direct link to the lungs, causing edema around the area of the capillaries, and therefore you'll end up with pulmonary hypertension, which can cause your pulmonary edema as well. Have a look at their hydration status through their urine output. Check them lying down, check them sitting up, see if they have any signs of postural hypertension, and maintain the education on the importance of diet, exercise, lifestyle changes whilst taking the medication. If they're taking diuretics, encourage them on the role associated with sodium or potassium, depending on which diuretic it is, which we'll talk about later. Okay, when someone gets put on hypertensive medication, it generally means that they're on it for life, but it does take some tweaking left or right in order to get the balance right. Okay, blood pressure is one of those things that changes all the time, and a person's body, activity, diet, emotional state can play a massive role in their blood pressure. So when they're taking the medication, tell them the telltale signs of lightheadedness, lethargy, complications of the drugs, and then get them to report back as soon as anything changes. It is generally a long-term commitment when starting antihypertensive medication, and if we can avoid giving it, we can just change it through lifestyle changes. It is always the best course of action. Okay, so talking of those non-pharmacological managements, we'll just focus on a few. So activity is important. The thing activity does is, yes, it does intermediately raise your blood pressure, but it trains your body in going from high blood pressure when it's needed and then popping back down to normal or a resting blood pressure, which is lower. than an activity blood pressure. So it'll actually train your body to going through these different states during sympathetic surge of exercise, a slight reduction during recovery, and then a full reduction when you're doing the repairing side of the house. So moving and activities helps with venous return, helps with flushing the system, and it helps train the system work better with this blood pressure. Now, nutrition is huge. Okay, if you have someone that's obviously eating poorly, that's the obvious one. But if you have someone with a massive sodium intake, who drinks a huge amount of water, or someone who has way too much amino acids or proteins, then that is going to play a big role in increasing their circulating blood volume and therefore their pressure. Talked about salts with nutrition. If they are on medications, they need to take it routinely, every day, same time, each day. They need to check their blood pressure regularly because, as I mentioned before, being hypertensive is asymptomatic. You won't realise you're hypertensive. So if you're taking your medication, doing all these lifestyle changes, and nothing is changing, then obviously something needs to be brought up. Losing weight is a very effective way of changing someone's blood pressure. Carrying a huge amount of adipose tissue on the outside increases the afterload pressure that is felt on the heart. That damages vessel, increases the risk of atherosclerosis and all the bad things associated with hypertension. By losing the weight, you'll still have the existing angiogenesis, so the vascular system that you put in place to feed that extra mass is still in place, which means your body can work more effectively, meaning the pressures don't have to be as high. So simply as losing 5 kilos can make a difference in someone's blood pressure. I read a study with a whole bunch of individuals and they had a mean change of 20 millimeters of mercury from individuals just from losing 10 kilos of body weight. Alcohol and smoking. Okay, smoking, we obviously know the risks associated with smoking and hypertension. We spoke about it during the cardiovascular lessons. Huge comorbidities associated with atherosclerosis, plaques, ischemic heart disease, the list goes on. When you're drinking alcohol, it affects your liver. When it affects your liver, you tend to have an increase in blood pressure because you're working harder for your poor liver to do the same amount of work that it was doing when it wasn't affected by alcohol. From there, you're also going through stages of chronic dehydration to rapid rehydration, and your body really can't regulate blood pressure that well when it's in those states. Stress and sleeping problems are conducive with anger. If you're stressed, you have your cortisol levels risen, that releases a full catecholamine response, which gives you a high blood pressure. Same thing, similar things happens when you're angry or when you're scared. You'll have a sympathetic response, which causes vasoconstriction and an increased blood pressure. When you are tired, your body is in overdrive, trying to keep your stimulus awake, trying to keep your higher functions awake. In order to do that, it makes your body work harder and increases your blood pressure. So, 8 lifestyle changes that people can do in order to lower their blood pressure. Now, you may be thinking that you have high blood pressure and you already do all of these things. Okay, you're very active, your nutrition is fantastic, you're not taking meds at the moment, you're not overweight, you barely drink, you don't smoke, and you sleep well. You're probably a little bit stressed and angry because who isn't? But other than that, you can't really think of anything else to change in your lifestyle. Now, when that is the case, then people start looking at hypertension, and then we start looking at prescribing medications from there. But recent times, it has changed from a focus that is just numbers based. Used to be if you were 140/90 with 2 blood pressures, then that was it, you got it. Okay, but new hypertensive guidelines have come out, and what they associate it with now is if you have hypertension plus associated risk of cardiovascular disease within the next 5 years or 10 years, depending on what they're graphing, if the percentage is high enough, then they look at prescribing pharmaceuticals. If your percentage of risk factors is low, but you have high blood pressure, then generally they look at doing nothing or monitoring it to see if things change. Okay, so the whole paradigm of hypertensive therapy has shifted away from being numbers, looking at it and go, oh wait, everyone's supposed to be 120, let's see if we can get everyone back down. They found out that that was actually causing more harm than good and over-medicating people. We don't want to give a medicine if we don't have to, because every medicine has the risk of side effects. So if we don't have to give the medication, we can change it with lifestyle changes. Or if you've done all the lifestyle changes and you don't have a high associated risk of cardiovascular diseases, then you won't actually end up getting the antihypertensive therapies, providing you see a good GP. Okay, well, let's have a look at these different antihypertensive therapies from a pharmaceutical standpoint. They lay up nicely in the A, B, C, and Ds. Okay, so we have all the A's associated with ACE inhibitors, alpha antagonists, and angiotensive antagonists. And then we have our beta blockers, our calcium channel blockers, and our diuretics. Okay, so it's the A, B, C, Ds of antihypertensive therapy is the way that they sell it. So let's start with our good old ACE inhibitor. Okay, everybody's favorite. Okay, now I can't say that properly because it's not actually the most common one that is given out anymore. Okay, but it's still relatively popular these days. So the way the ACE inhibitor works, it actually works twofold. Okay, so ACE inhibitor, okay, or your angiotensive converting enzyme inhibitor, works firstly, if you look at the angiotensive renin side of the house, it works by having that close link to blocking the angiotensive converting enzyme. Now that equates to not being able to produce your angiotensin 2 hormone. Okay, so in the absence of the angiotensin 2 hormone, you won't get that vasoconstrictive response, and you also won't get that release of your aldosterone. Okay, so you'll have your no vasoconstriction, reduces blood pressure, and you'll also have the lack of aldosterone, which stops the reabsorption of sodium and therefore water, which overall reduces the amount of blood pressure that you have. Now, all of the ACE inhibitors, which is what they're commonly known as, have the suffix that end in pril. Okay, so your ramipril, your catepril, your fusapril, okay, they're all ACE inhibitors. Okay, now one of the side effects associated with ACE inhibitors has got a strong link to do with the blocking of the bradykins getting absorbed up. Now, what bradykins generally do is they're the opposite side of the house. They cause your vasodilation. But if the bradykins can't get broken down because the ACE inhibitor is blocking it, then they end up building up. And one of the dangerous side effects associated with these drugs is it causes localized angioedema, okay, mostly of the lip or the tongue. So when that happens, they obviously get taken off this particular medication. Now, other side effects can be, obviously hypertension with that dizziness and headaches. You can get a productive cough associated with it, and that can causes your fatigue. Now, the cough comes from irritation within the lungs, because remember, the angiotensive converting enzyme is actually produced by the lung. So it blocks it right there, keeps it at bay, causes regional swelling, and then that gives you a cough. Non-productive one, but still highly irritating, and a lot of people will get off the drug associated with that. There's also a risk because of the block off of aldosterone, that you have an increase in potassium level. Because remember, aldosterone is also released in the presence of hyperkalemia, whereas now it can't be, because it still needs that flow-on effect. So because it's not doing that anymore, you can end up with hyperkalemia, which is obviously very dangerous. So that's your ACE inhibitors. Okay, that's one of them, and that's how they work. Now, your second one, which is similar, okay, but different to this one, to your ACE inhibitors, okay, is your angiotensive receptor blockers. Okay, now all of these ones end in your sartans. Okay, so most people have heard of your sartans before. Okay, so your isosartan, your irbsartan, candesartan is another one. They're all your angiotensin receptor blockers. Now these particular class of drugs, they allow angiotensin 2 to be produced, but then they block the angiotensin 1 receptor. And what that does is it stops vasoconstriction, stops the sympathetic response as well, and it also stops your aldosterone release. Okay, the difference is it doesn't have any effects on your bradykins at all, so you don't have that localized vasodilation or the big side effect associated with it. And it's a very good antihypertensive just by causing that general vasoconstriction. Now, this group of drugs is more well tolerated because it doesn't have the associated coughing problem that the ACE inhibitors do. But the drug itself is very slow acting. So it can actually take 4 to 6 weeks before it kicks in. And there's also a very, very big risk associated with this one if you give it to pregnancy or breastfeeding women, because it will come in and it will actually block the angiotensin 1 receptors of the baby. Now, babies are highly renin-based life forms, if you will. Okay, we rely a lot on our sympathetic drive. When they're babies, they're more associated with the renin, angiotensin, causing vasoconstriction to maintain perfusion in times that are needed. Okay, so if this drug is given to infants, it can be very, very dangerous. Okay, the next alpha on the list is your alpha 1 antagonists. Now, in particular, your alpha 1 antagonists. Okay, so these particular ones don't have any effect on the alpha 2s. Okay, they're also known as your peripheral acting anti-androgenic agents, if you want a lot of A's, okay, or your alpha A antagonists. Now, these particular ones, very simply, they block the alpha 1 receptor, therefore not allowing vasoconstriction, okay, or encouraging vasodilation. Okay, so the noradrenaline can't come along, can't activate the smooth muscle, so you can't get the vasoconstriction. Okay, that's it. Big side effects associated with it is postural hypertension, and then your peripheral edema as well. Okay, so that can play a pretty big role in this one when you're looking at it. But realistically, it's quite well tolerated. You do need to monitor the blood pressure, and you can look for additional signs of alpha receptor blocking, like people can end up with full nasocongestion. They can get quite fatigued, okay, because a lot of the nutrients aren't getting around to the body anymore, and you can get pupil constriction as well, okay, because it turns off the sympathetic response to the eyes as well. Now, each one of these particular drugs end in the zosin side of the house. So prazosin or doxazosin is another one, but they're all alpha 1 antagonists. Okay, that finishes the A's. Moving on to the B's, we have our simple beta blockers. Now, beta blockers work on both beta 1 and beta 2. So beta blockers will block your isotropic effect and your chronotropic effects. So it reduces the heart rate and the force of contraction. It also has a secondary effect of blocking the receptors for angiotensin 2 and the formation of aldosterone. Okay, so that's also a beta response in the body. Now, they can take 1 to 2 weeks before they are effective. Now, one of the side effects that you need to look out for is when you're blocking the beta 2, it can cause bronchoconstriction as well. And remembering that we give salbutamol because it's a beta 2 agonist, opens up your bronchies. This is actually constricting it. So people with asthma, COPD, respiratory conditions, it is 100% not recommended for those individuals because the treatments won't work. Okay, it actually blocks them as well. Another thing patients complain about with the beta blockers is they actually have insomnia, and even when they do sleep, they have very vivid dreams. Okay, so a lot of people don't like them because of that. They are reasonably common to be used. Each one of the beta blockers end in your olols, so atenolol, metoprolol, propranolol, they're all your beta blockers. Okay, so be aware if anyone's on them, especially if you treated them in the emergency sense, they do interact a lot with medications associated with androgenic or sympathetic drive. Okay, next one is your calcium channel blockers. Now these have a lot of different roles. As I've mentioned a few times in these podcasts, calcium is by far my favorite cation. It is responsible for so many functions within the body. Now calcium channel blockers or calcium channel antagonists, they're designed to stop calcium from flowing in to the cell. Okay, so the calcium that's in the cell, no problems. Calcium that's out of the cell, no problems, but they block this calcium from coming in. Now the good thing about them is they only block certain channels. So they don't block all channels, because if they did, well, you'd die. You wouldn't be able to contract, you wouldn't be able to clot, you wouldn't be able to do anything. So they block what's known as the L-based channels, but even with that, they have massive interactions with a lot of things within the body. So when a calcium channel is blocked, it stops smooth muscle contraction. Now what that does is it causes peripheral vasodilation, and that decreases the resistance, and therefore you treat hypertension. Now in this screen that you can see in front of you, you can see that it does a lot of other things. The only reason I put the rest of them up there is just to be aware that if someone is on a calcium channel blocker, just realize that calcium plays a huge part in our body's homeostasis, our second and third effects associated with coenzyme activities, and also muscle contractions and clotting cascades as well, even a link to memory. So calcium channel blockers are quite, I wouldn't say that they're dangerous, but they have a lot of interactions associated with them, a huge list of complications. The main one is hypertension and dizziness. You can get a flow-on effect of tachycardia in some cases, even though it's used to treat arrhythmias. Because calcium is used to prolong the QT interval, in the absence of it, QT interval is shorter, so you get an ability to have a re-impulse that can cause tachycardia. Each one of these drugs end in the ipines, so amlodipine or nifedipine are some of your main ones. Now, just because things are confusing in the medication world, we also have very common two, dilantazine and verapamil. They're also calcium channel antagonists, but they don't meet the rules of any of the ipine, just to keep us on our toes, because heaven forbid we know everything, hey. Now the last one that we'll look at, just for curiosity's sake, it's not a traditional antihypertensive, but obviously it works as an antihypertensive as well, and that is your diuretics. So diuretics work by removing certain substances from the body and therefore lowering the overall pressure by decreasing the blood volume. So traditionally they're used for APO, edema, when you have fluid overload, but they can be used in conjunction with other antihypertensive, in order to help control the amount of volume you actually have. These are particularly useful if one of your problems is associated with preloading. Now, because it's a diuretic and you're artificially removing something from the body, so you're actually you're overruling your body's chemistry when you use diuretics. So you need to be careful when you're doing it, because obviously a loss of one ion can mean a result of an increase in another ion, which can blow out your homeostasis, blow out your acid-base balance, and your osmotic draw. Okay, so it can have a lot of flow-on effects. The type of diuretics are broken up, associated with where they act on the nephron, and also what sort of compounds, molecules they're associated with. So as we move around our nephron, we'll start with number 1. Now these are your carbonic anhydrase inhibitors. Now a type of drugs is your acetazolamide. Now what these particular ones are is they inhibit the carbonic anhydrase in the proximal convoluted tubules. So as far as a diuretic goes, they have a very small diuretic effect, but they increase the elimination of bicarbonates. So they're quite effective at getting rid of bicarbonates with a little bit of water. Okay, so they have very little effect on your sodium potassium as they go along. Massive effect on your pH, but not a very strong diuretic. When we get to our osmotic diuretics, now these affect the entire tubule. So when you give given an osmotic diuretic like mannitol, it infects the entire tubule, but it predominantly acts on the straight segment of the descending loop of Henle and the proximal tubule as well. Now it increases your blood and tubular fluid, so it increases the osmolarity of that, and that increases urinary flow. So it's very effective at decreasing your intracranial or interocular pressure. That's why mannitol is often given associated with those two conditions, as well as APO, things like that. As we move around to number 3, we get into our classic loop diuretics. Now, furosemide is one that most people have heard of. Now, loop diuretics inhibit sodium potassium chloride contra portals, so it stops them actually transporting, so con-transporting through the actual loop of Henle, and with that it actually holds on to fluids as well. So because it's stopping sodium, massive osmotic draw, double chloride, massive osmotic draw, and potassium, it holds on to a huge amount of water. It does increase your pH a little bit associated with the potassium loss and overall sodium loss as well. It also has a flow-on effect to losing calcium as well, just to keep us in the loop. Okay, the next drug, as we're moving along, number 4, your thiazides. They're associated with, again, inhibiting sodium and calcium con-transporters, but these work at the early distal effects. So they have a greater loss of potassium compared to a loop diuretic, and they're not really effective if someone's glomerulus filtration rate is less than 30 mils a minute. Okay, so if you have a low glomerulus filtration rate, you wouldn't use your HCTZs at all, or your thiazides, because it's not very effective when you get back to the distal convoluted tubules. Now the last diuretic is your potassium sparing diuretics. Now these are quite interesting because they sort of link in right at the end, and they work with your aldosterone receptor antagonists. So that's basically what they're known as. So they inhibit the expression of sodium channels in the collecting ducts themselves. Now, blocking the sodium channel in the distal convoluted tubules and the collecting ducts obviously increases the amount of sodium that gets lost, and that leads to a decrease in reabsorption and a decrease in secretion of potassium in the distal convoluted. So we have our fluid loss, not as much as our loop diuretics or osmotic diuretics, but still fluid loss. We have a lowering of pH because of the maintaining of potassium. We lose sodium, but we maintain potassium. So it can be a one that was used if somebody is suffering from hypokalemia itself. Okay, but like I said, they're not really associated with hypertension, and obviously there's a huge amount of side effects that can come around. So hyperkalemia with metabolic alkalosis, hyponatremia, hypomagnesia, calcemia, glycemia, lipidemia, and even uricemia can be side effects associated with using your diuretics. So good little conjunction type ones or any intermediate type ones, but not the first line of defense when dealing with your hypertensive management. Okay, that is everything we have on hypertensive pharmacology. I hope you got something out of it. What I'd take-home message from this particular one is all the medications that can be given for hypertension can have pretty severe side effects. The things that are being stopped with these medications are biologically designed and regulated by systems that's pretty hard to track. So if you are using them, make sure you use them in conjunction with the lifestyle changes and encourage your patients to do so, because the goal will be to be able to maintain a safe blood pressure in the absence of cardiovascular risks and also in the absence of antihypertensive medication when they can be avoided. But until next time, take care.